Now in this section we will talk about one very common sexual dysfunction of the male, and this is the erectile dysfunction. In erectile dysfunction, we will talk about the epidemiology and pathophysiology of erectile dysfunction, medication related erectile dysfunction, what are the different medicines if they are taken by the patient and they cause erectile dysfunction, and how we can approach to the patient with erectile dysfunction. So erectile dysfunction, what is erectile dysfunction? Is the inability to get or keep an erection. That's the erectile dysfunction. Epidemiology of erectile dysfunction, these are the percentage of men affected by the erectile dysfunction, and this is the prevalence of erectile dysfunction. How prevalent it is. Combined type is common in is present in about 52%. So that's the most common combined type of erectile dysfunction. Then the moderate in severity is 25%, minimal is 17%, and complete erectile dysfunction, complete inability of erection, is in 10% of the cases. Higher in men with medical disorders. So different medical disorders can cause erectile dysfunction. Endocrine and cardiovascular disorders are the common disorders that can cause erectile dysfunction. Smoking is another risk factor associated with this disorder. High incidence in radiation or surgery for prostate cancer or lower spinal injury. Lower spinal injury, we said the neural control is in the L1, L2, that's lower spinal area. So any injury that involves that area can cause erectile dysfunction, and also any surgery or radiation for prostate cancer can cause this problem also. Pathophysiology is mechanism of the erectile dysfunction. It can be failure to initiate the erection, can be psychogenic, endocrine disorder, or neurogenic. So three factors mainly involved in the failure to initiate, and that is mainly in the brain, psychological, some hormonal disorders which can be under the endocrinological problems, and then there is neurogenic involvement. So all these three conditions can lead to failure to initiate. Failure to fill, if it's arteriogenic problems, can lead to failure to fill. Failure to store adequate blood volume within lacunar network is any veno-occlusive dysfunction. So three mainly mechanisms are involved in the pathophysiology. It's failure to initiate, failure to fulfill when there is naturally any problem in the arteries. If they are not filled properly, it can cause erection problem, and also if there is a veno-occlusive dysfunction and there is failure to store adequate blood volume. These are three main mechanisms involved in the pathophysiology. Medication related, there are some medicines that can affect the men. 25% of men, they are associated with the medication induced erectile dysfunction. They have additive adverse effects which can cause the problem. The common drugs that can lead to erectile dysfunction, we have antihypertensive. These are the drugs used for high blood pressure, which include calcium channel blockers, diuretics, methyl dopa, clonidine, reserpine, and beta blockers. Antihypertensive, lot of patients use them because of high blood pressure. So if the patient comes with the disorder or erectile dysfunction, it's important to ask them in the history, and when you talk to the patient that what medicines they are using, and if they are using any one of these antihypertensives, it's most likely as the adverse effect of those medicines. Then another medicines like cardiac and antihyperlipidemic drugs include digoxin, gemfibrozil, which is anti-hyperlipidemic, clofibrate, and then antidepressants commonly cause this problem if the patient is on the depressive drugs. Selective serotonin reuptake inhibitor, tricyclic antidepressant, lithium monoamine oxidase inhibitors, then tranquilizers like butyrophenones, phenothiazines, H2 antagonist, ranitidine and cimetidine, all they can cause erectile dysfunction. Hormones, progesterone, estrogens, corticosteroids, GnRH, gonadotropin releasing hormone agonist, and 5-alpha reductase inhibitors, cyproterone acetate. Then some cytotoxic agents, drugs used for treating the cancer. We have cyclophosphamide, methotrexate, roferon A, anticholinergic drugs like disopyramide, and anticonvulsant. Next, approach to the patient. History is important: medical, sexual, and psychosocial history. Approach to the patient is very important. Make sure history is very important, and this is the condition in which the patient is not very comfortable in discussing these situations. Complete history about any medications. We talked about so many different drugs that can cause this problem. So it's important that you should ask the patient in detail if they are taking any of those medications, if they have some medical problems that can lead to this condition, or they have any psychological or psychosocial issue that can lead to this problem. And important is that you should have a patient and doctor have a good bonding between each other, so they can tell them all the information about their problem. Then also physical examination is important. On the lab testing, serum level of testosterone and prolactin should be measured. Lifestyle, risk management, medication review. So all these are important when you approach to the patient and ask the patient about the problem they have. If the problem is resolved after discussion with the patient or approach to the patient, then we don't need any further treatment. But if the problem persists, then we should patient-partner education, goal-directed therapy planning. Sometimes the therapy of both the partners is very, very effective in treating this condition. If the sex therapy and special testing is performed for the couple. And it should be goal-directed therapy. Vacuum device is another approach to the patient or the method of treating the patient. Oral PDE inhibitors is effective. Treatment, if the treatment is successful, then we don't need again any therapy. But if it's not successful, then intraurethral injection or injection therapy is used. So these are different approaches. If the condition is resolved just by talking, then we don't need any further treatment. If not, then we should do the patient partner education, special sex therapies, special testing is performed, and then we can also try the oral medicines. If the treatment is succeeded, then it's fine. If not, then we should use the injectable method. We can also try the vacuum device. If the treatment is successful after the intraurethral injection therapy, then we do nothing. But if not, then we should try implantation and vascular surgery. So approach to the patient, again, different steps are used, and if there is success after one step, we don't need to go further. But ultimately, until we get the complete success, we need to monitor the patient. We want to do different therapy steps and special testing techniques so patient can benefit from these different methods. So this was all about section 2. Thank you for watching sqadia.com.